So again, everyone, welcome to today's Lunch and Learn webinar series on integrated chronic disease prevention with Dr. Peter Selby. Now, if you are interested in obtaining a letter of completion for today's webinar, you must have completed the online registration form. You must complete the full hour of the live session using your first and last name, and complete the online evaluation following this webinar, which will be emailed out to you guys all this afternoon. These webinars are being tweeted live. Follow the CAMH Nicotine Dependence Services on Twitter at @PSQuitSmoking. And to follow the live tweeting and to post your questions, use the following hashtag #TeachWebinar. Today's faculty presenter is Dr. Peter Selby. He's the Chief of Addictions and Clinical Scientist at the Center for Addiction and Mental Health. He's a professor in the Departments of Family and Community Medicine and Psychiatry, Faculty of Medicine, and the Dalla Lana School of Public Health at the University of Toronto. He's the Executive Director and creator of the TEACH Project and a principal investigator of the Ontario Tobacco Research Unit and the STOP study. These are Dr. Peter Selby's disclosures. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Content of slides are primarily based on evidence-based guidelines, including the following 3 sources. These materials, as well as a verbal presentation and any discussions, set out only general principles and approaches and do not replace the need for individualized clinical assessment and treatment plans by healthcare providers. Now, before I hand it off to Dr. Peter Selby, I just have a few polling questions for everyone. Okay, so the first question is, what type of organization do you currently work for? Okay, and great. So it looks like the majority of you are coming from a hospital. Next question is, what region are you currently from? Okay, great. So it looks like a large portion of you are from outside of the province, outside of Ontario. And lastly, what discipline do you belong to? A large portion of you are registered nurses. Great. So thank you, everyone, for participating. I'm going to hand it over to Dr. Peter Selby now.
Thank you. Welcome. So for some of you, this may be a bit of old hat, but for others, this might be new information. So I appreciate that we have people here from different disciplines and different ways of thinking about this. Excuse me. Sorry, I'm not sure what happened. Sorry if that was too loud. Anyway, what we want to cover in today's learning objectives is want to identify the contributing risk factors and modifier behaviors for 4 major categories of non-communicable diseases, and many of them, we'll go quickly over them, but really pay attention to number 2, which is how do we address these chronic disease risk factors such as smoking, potentially if you have time for prescription medication, alcohol, nutrition, depression, and exercise with patients when they all seem to cluster in the same patient. And then how can we use motivational interviewing that will allow us to assess and intervene with them when they have these multiple behaviors to change. So roughly that's what we plan to cover today. And again, this is introductory. Some of you may not find this very in-depth, but we do have more in-depth courses about it. But for today, we're going to give you a rough overview of what we do in this area. So what got us to focus on this is that people who smoke tend to actually suffer excess poor health more so than that can be accounted by their smoking alone. Which means there are other things going on in people who smoke that go beyond just their tobacco-related causes. And when we looked at that, we started doing some searches, and we came upon that basically unhealthy behaviors and chronic diseases are essentially what the modern problems medicine faces. They are long-term diseases that develop slowly over time, and in general, we don't have cures for them, but we can control them. And ideally, we should try to prevent them. And again, many governments have said, look, this is preventable. So how come that most of our healthcare budgets are going towards taking care of preventable conditions, and we're not slowing down that tsunami in any meaningful way? In part, the problem is that, like in this graphic, each person, each sector touches a different part of this big elephant and thinks that they have the right answer. And what is required is for us to actually have a common language and a common way of communication across sectors, whether it's public health, primary care, whether it's hospitals. We need to have a way whereby we actually communicate around the care of patients, and patients have the language as well, so that they can understand what is going on in a meaningful way. So one of the downsides that we have here is that we often do not consider an integrated disease prevention strategy, because although these risk factors cluster and they interact and they impact chronic diseases, often our systems are trained to be siloed off, right? So we have somebody who works on smoking cessation, we have somebody else working on diet, we have somebody else working on exercise, we may have somebody else working on stress, and generally we're not able to put it all together. So even though the person coming to us has all these things coming together. And way back in, this was 2006, that this paper was published by, this is Dr. Ream. And when we took a look at the chronic diseases, the determinants and risk factors, we saw that there was a lot of interaction and clustering of smoking, unhealthy eating, physical inactivity, obesity, alcohol, illicit drug use. And because these are the bedrock on which other conditions develop, we were not seeing the root cause. We were only looking at the COPD or the esophageal cancer and high blood cholesterol or type 2 diabetes or cardiovascular disease, but we weren't really going back to where the illness was. And we were not paying attention. We were mainly paying attention to this and maybe some of these risk factors, but we weren't really paying attention to these. And I think that's where we started saying, wait a minute, we need to start paying a close attention to that. And what is a framework? Because as you start paying attention to more than one health behavior, it starts becoming more and more complex and less manageable. So we said, okay, if you look at how our health system is structured and all the governments fund, we have these strategies for cardiovascular disease, diabetes, cancer, mental illness. If you move further down into primary care, we are paying attention to a little bit of high blood pressure, cholesterol, lipids, glucose intolerance, obesity, overweight. But really, it's these modifiable risk factors that often have been called as prevention where we actually need to make the big shift. Because if we don't make the shift here, we're going to keep trying to mop up over here or here, whereas if we actually get this right, we can reduce the number of people who have these conditions that follow. So that's the rationale. Now, how do we go about that? For example, and as clinicians, we may see somebody coming into a clinic or into the hospital, or where you have a person who's now more and more younger than before. They're newly diagnosed with diabetes. They're overweight or obese, and they're still smoking. They live alone. They eat their meals on the go. They're working, but they have a family history of multiple diseases like diabetes, obesity, and heart disease. Now, where do you begin with this person? And if you start asking, maybe she's also drinking to excess. So where do you start helping this person make behavior change? Do you just say, okay, you know what, I'm only going to worry about the diabetes and nothing else? Or do you pay attention to all the other conditions that can make her life worse? So I'm going to skip over this slide because I don't think it adds too much, but I want to get to the next slide, which is, this one. This slide is one of the most important ones in which we have to understand these chronic disease, these chronic health behaviors that lead to disease. So if you look at this part, the human action or behavior, that's what we do. So whether we are sedentary, whether we smoke, whether we drink to excess, whether we are physically active, whether we eat healthy or we don't eat unhealthy, whether we manage to give ourselves enough rest time and sleep and manage stress, all of this is determined by an interaction of the environment, by the opportunities and constraints that the environment allows for that person, and the biological underpinnings. That means the genome, your genetic makeup, your molecular level, the cellular level, the organ level. All of this interacts with these factors and determines how we are going to behave. That's a very cross-sectional way of looking at human behavior. So let's, for example, take alcohol drinking. If you live in a country where alcohol is sold and it's a part of the culture, and you live in a neighborhood where the LCBO or the alcohol outlet is right next to your house, and there are lots of alcohol outlets and there's lots of advertisements, and your family also engages in alcohol consumption in a binge pattern, and there's alcohol available, the opportunities to drink are much higher because there are no constraints that are coming from the environment with respect to drinking. Now, as laws come in and there may be no drinking and driving, suddenly there's a constraint coming in. So the net consumption of alcohol might change, the pattern might change. But these factors affect how this person is going to behave. On the other hand, their genetic background may determine whether they drink to excess or not, or whether they actually have inbuilt constraints to drinking. For example, there are some people who drink, if they drink, they get sick, so they don't drink as much, and therefore that creates a biological constraint, and it doesn't matter how many opportunities there are for them, they just don't drink. So this gives an example of a cross-sectional thing. However, this human and the behaviors we do are determined right from our prenatal to our early childhood to adolescence, because as we are growing up, these environmental influences are interacting with our biological systems, and that is determining how we're going to go. So that's why we can't look at human behavior just in terms of the opportunities and constraints interacting with the expression of biological determinants. We have to take a look at it developmentally. What has happened before as to why this person is either drinking to excess or smoking or is stressed out or is not eating well or is not physically active. These determinants of these behaviors in the moment have a historical trend to it. And this really helps us understand how to bring in the social determinants of health into any kind of risk behavior thinking that we might be trying to help patients with. So many of you who work in primary care are familiar with this, that to get improved outcomes for chronic disease, we need productive interactions between an informed, activated patient and a prepared, proactive practice team, but we make sure that there are good resources in the community and that support self-management and the health system of how care is designed with the information that people can make the right choices the right time when the person shows up. And when you have this, the interactions are productive and you get an improved outcome. And this chronic disease model of Wagner has been used many times, especially in primary care reform. So that's the background ideas around how we can think about it. And then there are these big four non-communicable diseases that are accounting for most of the death and morbidity and mortality in society today. If you take a look at the burden, 2/3 of deaths in Canada each year result from these chronic diseases. 1 in 2 of us will develop cancer in our lifetime, and 1 in 16 are living with diabetes. 1.6 million Canadians have a heart disease or living with effects of stroke, and over 3 million Canadians are living with a chronic respiratory disease. And this is not a sustainable condition. I mean, if we want to have a publicly funded healthcare system for the future, if we don't pay attention to how to prevent these things, we're going to land up with a bankrupt system. However, when you take this back and start looking at the risk factors for all these chronic diseases, which many risk factors are risk factors for many chronic diseases, smoking is about 18%, 19%, depending on the survey. It can be, and where you are, it can go down as low as 12% or even lower. But generally, on average, it's about hovering around the 20% mark. Heavy drinking, where they're drinking excessive guidelines, about 15%. No physical activity, 50%. Half of Canadians have no physical activity. 18% will meet the criteria for obesity, and 24% perceive life to be stressful. If you think about this, this is an interesting kind of statistic because especially in a heavily resourced country like Canada, 1 in 4 of Canadians are feeling stressed. When there is no fear about lack of food, drinking water, shelter, etc., 1 in 4 are walking around feeling life is stressful. Now, what does that translate to into burden? And we can see the burden in Ontario because that's where the data has come from. I haven't got reports from other provinces, but 60% of deaths in Ontario can be attributable to smoking, alcohol consumption, poor diet, lack of physical activity, and stress. And nearly all Ontarians reported at least one of these 5 behaviors. Only 1.4% had none. So, you know, it's an interesting thing. All of us are sitting with these risk factors for chronic disease. And collectively, having those risk factors reduces the life expectancy by about 7.5 years. And if we want to reverse that, the greatest impact, again, will be if we reduce levels of current smoking, increase physical activity, and reduce unhealthy eating. So that's where we know what we can do to improve people's longevity and quality of life. So after we've done a search of all of these behaviors, we put them into a pack of 6, and we call it the Health Promotion 6-pack because 1, they cluster in the same population. 2, they are health behaviors that are modifiable, that they have developmental aspects to them, they have environmental determinants, and they have biological determinants. And if we actually are able to understand this, then we can teach it to both our practitioners as well as our healthcare, as well as our patients, that roughly all these health behaviors have underlying determinants that if you start working on them, you can make a change in how you, whether you smoke, whether you drink alcohol to excess, how you manage stress, how you sleep, whether you're physically active, and what kind of nutrition you put into yourself. Ironically, we chose the 6-pack because we know if any of these are out of whack, this gut starts to protrude. And if you see the amount of truncal obesity, which is a more dangerous kind of obesity, is quite prevalent now in Canadian society. In sometimes even in people as young as 15, you're beginning to see that most people don't have this kind of gut, me included. So smoking, for most of you know the smoking, again, these are just the cancers, the laryngeal cancer, lung cancer, heart attacks, and stroke. And if you take a look at the expenditure just in Ontario, it costs $2.2 billion in direct healthcare costs and $5.3 billion in indirect costs. So this is costing us about $7 billion just in Ontario. Physical inactivity is, we know what happens. If you're more active, you can reduce the risk of type 2 diabetes, skipping heart disease, cardiovascular disease, and we also know actually from other studies that it can also help reduce cravings to smoke. But physical activity also indirectly prevents obesity and promotes healthier distribution of body fat. So you reduce your insulin resistance, you're less likely to have abdominal fat if you're more physically active. But look at how much the fact that society has become so inactive, it costs us about almost $1 billion in direct healthcare costs and $2 billion in indirect costs. And again, this is another thing that is certainly amenable to change. Alcohol, again, alcoholic beverages are basically carcinogenic. They've been classified. It's just that because of the cultural way in which we look at alcohol, no one even thinks about it. But it is convincingly the cause of oropharyngeal cancers, laryngeal cancers, esophageal cancers, colon and rectum cancers, liver cancers. pancreatic cancers, and breast cancers. In general, there's no safe level of alcohol consumption to avoid cancer risk. I mean, basically, no drinking is the best option. If you take a look at how much alcohol costs us, it's costing us an estimate of 1.7 billion in direct costs and 3.6 billion in indirect costs. So these are costly substances that we use in society. Again, users of any drug, which includes abuse of psychoactive pharmaceuticals since 2008, approximately 1 in 6 users have had some harm in the past year due to their drug use, so 17%. And again, it's costing the economy nearly $23 billion annually. So moving right along to nutrition, we know healthy eating may protect against chronic diseases. We're not sure. But what it certainly does, it influences the intermediate factors such as whether you're going to be overweight, your obesity, having high blood pressure, for example, whether you're going to develop diabetes. And one of the issues is that vegetable and fruit consumption, after controlling for everything else, is an independent risk modifier for chronic disease and a good marker of overall diet quality. And in fact, it's some of the questions that we ask in surveys is about people's consumption of fruit and vegetables, not counting juices. And again, this is where people get dietary fiber, and again, it's thought to reduce risk of cancers, and again, protection against heart disease and diabetes. Another food source which seems to have slipped into our diet, and we are really, as Canadians, are one of the few countries where we consume more than twice the recommended adequate daily dose for adults. And for example, if you eat one slice of pizza on an airplane flight, you will actually land up exceeding your daily consumption of sodium, for example. And again, if we are able to reduce the sodium to the recommended level, high blood pressure would go down by 30%, prevent nearly 23,500 cardiovascular disease events each year in Canada, and generate direct healthcare savings of $1.38 billion annually. So we know that these are things that if we do, we would be able to actually improve the health of people. Another part which we cannot ignore is that people feel stress. And stress is basically when the system is experiencing things that are leading to a discomfort and interfering with the quality of life, and that leads to the release of stress hormones in the body, and that in turn leads to the development of chronic diseases or mental illnesses. When we take a look at this, 1 in 5 Canadians is affected by mental illness every year. This burden in Ontario is 1.5 times that of all cancers and more than 7 times that of all infectious diseases. The burden of depression alone is more than that combined burden of lung, colorectal, breast, and prostate cancers. So when you start looking at this, here is something that is so common, but it's most poorly treated and managed in society. And again, coming back to more sort of basics, which we've heard about it, what we do is sleep. And 3.3 million Canadians have problems falling asleep or staying asleep through the night. Again, why is that important? Because we know lack of sleep and weight gain are related. If you get less than 6 hours of sleep each night, you're 23% more likely to be obese. And again, if anybody with, for example, sleep apnea, if they're trying to lose weight, it's almost impossible if they don't get that sleep apnea taken care of. If they have depression, they can get better if their sleep apnea is not taken care of. And again, depression causes the sleep to get worse, so they are in a vicious cycle. And again, poor sleep chronically is associated with long-term health consequences, including diabetes, blood pressure, and heart disease. One of the other things is that, which is really striking to me, and I think because we are a health audience and we need to pay attention to this, is that prescription medications are in and of themselves a problem. And right from the beginning, from when we started giving people medications, and you can see Philippe Pinel from France in the 1800s, late 1800s, late 1700s, or late 1800s, said, for in diseases of the mind as well as in other ailments, it is an important art of no little importance to administer medicines properly. But it is not an art of much greater and more difficult acquisition to know when to suspend or altogether omit them. So we are a pill-happy country, and a lot of the conditions that we are caused by medication errors. And hospitalizations, many hospitalizations, 1 in 4 hospitalizations sometimes, depending on the state, can be accounted for by the medications we give patients. And so we need to pay attention to whether our medications are actually doing harm, either the drug itself or how we give it or how people take it are causing harm. And again, those are behaviors. Taking medications, giving medications are behavior that have roots in how we can modify those behaviors. So how do we reduce this burden? We need to increase life expectancy up to 3.5 years. If we do this, if we got 37% to become more physically active, we got 29% to improve their diet, and 22% to quit smoking, we could really help these people increase their life by about 3.5 years. All of us, actually, because many of us are not as active as we need to be, or we're not eating as healthy as we can. And again, this is just a slide that shows you through ISIS in Ontario that what is the impact of eliminating smoking on healthy alcohol consumption, physical inactivity, inadequate diet, and high stress on life expectancy and health-adjusted life expectancy for Ontario adults. And this is from 2007. You could be gaining that 7 years if we were able to get rid of this. So what is the underlying reasons, and what can we do to deal with these risk behaviors? We know they all have social determinants of health that modify them, and there are these biological determinants, and they're common across, but we treat them in isolation, and we have to start asking ourselves, why do we do that? Because it's not efficient. We have one person in front of us, a patient, or a person from the public who's coming for help. Why is it that we are parceling them down into separate disease categories or separate risk factors when they have all of them coming together? So, again, we also understand that these things occur within the social and cultural influences of their behavior. So when we're starting to approach this issue, we have to understand that we have to be flexible, and we have to tailor it on the needs and the priorities of the individual, because we can't overwhelm them and say, okay, I want you to stop smoking, stop drinking, get fit, start eating fruits and vegetables, start sleeping 8 hours a week, and manage your stress. And most people will say, I can't do that all at once. So we need to figure out where the person is at and what they can tolerate. And in part, because the evidence base in science is hard to study these kinds of things, we have to balance the innovation and the evidence. So why is it particularly hard for us in acute care is that people are coming in with acute life-threatening conditions. We have limited time. We prioritize that over everything else. We believe these other factors are more important, and sometimes we are unaware that there are things that we could do or the patient can do themselves. And we may not be ready, or the patient may not be ready for change. And again, the time crunch often comes in the way to actually integrate this within our appointments or within the setting where we find ourselves meeting the patient. And again, one of the things that we do know is that there's no magic bullet, but what we do know is that there are ways to motivate behavior change in society, and these have been effective for each of individual risk factors. And can we actually sequence them to help people make the changes? One way is to get people motivated is to do obviously things like a life expectancy calculator, and they can calculate their own life expectancy with this based on their use of smoking, alcohol, etc. And again, it can start being that motivator in your practice for your patient to think about what can they do to improve the quality of their life, improve their longevity. Now, although we told you what the general population prevalence, you actually get a higher prevalence often within our primary care practices. And so really when you look at it with these risk behaviors, you can get a higher prevalence than what your region has. And again, you'll see mostly people are being physically inactive and not eating their fruits and vegetables. Now, again, this is it's a classical study by Kaw et al., and it's the EPIC Norfolk Prospective Study where they looked at 20,000 men and women between the ages of 45 to 79. And again, they looked at these risk behaviors: alcohol, smoking, plasma, indicating fruit and vegetable intake, and looked at scoring them. And essentially, if people had all four negative behaviors, right? So smoking, drinking, not eating fruits and vegetables, being physically inactive. Basically, what happened is they were, if they were 14 years older. And if you did have it, you were kind of 14 years younger than your chronological age. And again, these four behaviors predicted a four-fold difference in total mortality. And in this study, estimated equivalent to about 14 years of chronological age. So it ages you faster. But what came out of that study was that small differences in lifestyle may make a big difference to health in the population and encourage behavior change. So whether you're coming into this from public health or from clinical medicine, helping people along these behaviors is going to make a difference to their quality of life and their health. Unfortunately, it becomes complex because, as we said, there are all these issues coming together. The lifestyle issues, the comorbid diseases, the socioeconomic status, language may be coming, housing, and these other social determinants all come together, leaving us feeling overwhelmed. So one way when you're feeling overwhelmed is we said, let's make it simple. We know we want to have a patient-centered biopsychosocial approach. So what would this look like? And so in a planning sheet, when we're looking at a patient, trying to help them sort things out, and as we are thinking through our problems with them, we look at each of these behaviors, we identify if they are there or not, and then take a look at what are the issues in the environment that are causing the problem, what are their own person's behavior, how they're doing that, making the problem worse, and are there biological predispositions that are making these things worse. Once we understand that, are there solutions or resilience factors that can help the person get better in these domains? Or what can we do to mitigate against some of the problems? So for example, let's say for example, somebody is drinking alcohol to excess and is dependent and they can't stop. Is the solution a potential pill for that particular issue to help them manage that biologically because they can't stop spontaneously? On the other hand, that behavior of their drinking, are they amenable to counseling so that they measure their drinks, they follow the reduced drinking guidelines, and they don't let themselves hang out in bars and places where alcohol is served, for example. So that's another way to do that. And then the other way is that we look at deconstructing these silos and starting to navigate and help the person navigate through this forest of complexity. So we use motivation interviewing as one way to help us do that, because there are too many things to change and people feel kind of overwhelmed. Our first one is to help set the agenda. So how do we bring this together in the clinic is that we have to bring and identify all these things. And we say, Mr. Jones, for example, I noticed that you drink, you're smoking, you have all these things. Would it be okay if we talked about one of them? Which one would you like to talk about? What is your understanding of how your drinking is related to your smoking, is related to your physical activity, your stress, etc.? And that's key to get to the next stage. And often what happens is we pick a topic to jump down, the patient's not ready, and then we get the resistance. And what I would suggest to you is we work wherever there's going to be success in one area, because success in one area may lead to progress in another, and this is by Steve Roenick, who's one of the co-developers of motivation interviewing, where we notice that if people make behavior change in one area and they're successful at it, they're more likely to try making a behavior change in another area as well in future. So one of the things that you can use is this worksheet with the patient and say, some of them may be filled, pre-filled, or they can fill it themselves. And they may put the bigger problems in the bigger boxes and the minor ones in the smaller boxes, but really the idea is you have a tool by which you can map out and the patient can see all the problems that they have. And the other way I can use this with my patients is say, okay, so what do you think is the relationship between controlling weight and smoking, or your stress and smoking, or your medication and your weight, or your physical activity and stress? How is that related? And having that conversation gets people thinking about how, oh yeah, if I quit smoking, I may gain weight, but if I actually exercise and I eat healthy food, this may not be a problem. On the other hand, if I'm stressed, I need to figure out how not to eat when I'm stressed, and I may need to think about what I can do instead. Or if I'm on a medication that causes weight gain, like an antidepressant or a neuroleptic, what are some of the things that I can do so that I don't gain more weight, right? So this bubble sheet or agenda setting worksheet can help you help the patient navigate through that forest of complexity. Just in the interest of time, I'm going to move forward. So one of the things that we have seen here is I'm going to just open it up a little bit, and we're going to open it up for interaction and typing, is that in chronic diseases, I'm going to present to you a case that seems pretty relevant, and we get these patients in our clinic, and I've heard from my colleagues they get a similar kind of thing. So let's start off with this. When we started our clinic here, we used to only focus on the smoking. But very quickly, it became apparent to us that other factors were going on in the smoker's life. And Lucy is a composite of one of those cases, of some of those cases. So let's take a look at this. So 4 months ago, Lucy's husband left her after 15 years of marriage. Being a stay-at-home mom, no university education, been able to find a part-time job at a grocery store. Trying to raise 2 young daughters, aged 8 and 13, struggling emotionally and financially. Never lost the weight she gained from her second pregnancy. She's about 40 pounds overweight, suffers from hypertension and asthma. She's smoking 20 cigarettes a day, which severely affects her asthma. Her husband quit a year before, and he left, and in the last year of their marriage would bicker about her smoking and the impact it had on her health and her children. Now that he has left, he has become even more vocal about his disgust towards her smoking, which has led Lucy to fear the custody of her daughters. Again, she's more anxious and has difficulty sleeping. And she's discovered alcohol before bed. She often has a better sleep. This has led to her drinking 5 to 6 drinks a night, 2 to 3 nights a week. She feels lost, she feels sad, alone, and with nowhere to turn. So you can see how this case comes up. There's a whole bunch of stuff happening. So the question is, if you had those agenda setting skills, how would you apply it, and how would you explore what the priorities are? And the second part of that is, how would you respond to a resistance when discussing her health behaviors? So for this part of the talk, we're going to have you just type in on this on the chat box. I'll bring the case up again so you can read it. Take a few minutes and just start typing how you might apply this agenda setting worksheet to Lucy. Yeah, so I think Deborah ask the patient first. So one way in which we can ask the patient first to say, first thing is when she says, they say, wow, there's a lot going on, empathize with her, and say, okay, so there's, I've heard that there's a lot of things going on. There's the asthma, there's the smoking, there's your fear and anxiety, there's the alcohol. How do you see this? How do you see these interacting with each other? Of course, you get permission to ask and say, you said a lot, and it can be quite overwhelming, and especially people like this will feel kind of overwhelmed. And we spend a lot of time initially acknowledging that this is overwhelming, but it's not hopeless. And that with permission, if we bring the sheet out, often it helps people just sort of make sense of all these behaviors and this feeling of being overwhelmed, and it starts saying, okay, the first step might be a small step, but let's see how we can get to where we need to work, and that bubble sheet helps do that. And again, she might be interested in getting her daughters to be involved. And so the next part of this issue is to really say, okay, here are the behaviors. What are some ideas that they have in trying to address them? And again, I think you're right, Christina said, about how do you connect these dots, help them connect the dots, because people sometimes will report to you and they haven't connected the dots, and if you do that, connecting the dots, they say, oh, I can see why my anxiety and my fear of losing my daughters, which is related to my smoking, is causing me to drink, and maybe I need to first pay attention to this piece, and then everything else will fall in line. So they start problem solving as you're helping them connect the dots. Exactly, and as Darryl said, there's lots going on. So helping her prioritize is critical. What you have to be careful is that we don't say, oh, well, there's too much to do, let's not do anything, and not let her get frozen. Because when too many things are going on and people are stressed, you get the flight or fright response come in, and people just stop trying, and they just go in like a zombie. And often what happens is then they either drink more, smoke more, eat more, don't get active, and really get into a self-destructive pattern rather than coming out of the problem. So I think the comments have come back is really about helping her choose the goal at a time, and what is reasonable, and what can the person actually accomplish, because they don't always agree with what our priorities are. And so it's important to make sure that there's a shared agreement on what she's working on, and she's going to work on. Okay, so I think we've got a lot of that in through the comments. Yeah, and again, focusing on the strengths, and feels like she's already feels possible about herself and how low her self-esteem is. Right, focusing on her strengths is really an important piece of it. Is saying, often in motivation interviewing, there's something called an affirmation, and we'll say an affirmation is a recognition of a strength. So it could sound something like this. Of course, it has to be genuine to say, I notice there's a lot going on, Lucy, and it's really takes the courage to come in and make the time to come in and talk about this, because it's very easy to just give up, and you haven't. So an affirmation like that helps them recognize that they've actually taken some steps towards addressing it, that they want something different. So focusing on a strength, really, you're absolutely right, Christina and Mike, it strengthens the relationship from which a lot of the difficult work of behavior change can begin. Right, and again, we're going back to this, I'm just going to show you that. This planning chart, after you've got the agenda chart, you can sometimes pull this out and say, okay, so, let's look at what are some of the things going on around you that make you want to smoke or be physically inactive or drink or not eat healthy or make you stressed or interfere with your sleep. And you'll be surprised sometimes when you start doing it, starting with this column first, it's not as blaming. What are things outside of yourself that are doing it? If you want to look at it. What are the things that you have under your control that may be doing it? That's your behavior. And biology is something that which medications or the biological things can help. Now, clearly, you can't have a medication for biological activity, but for example, if somebody does have a thyroid, hypothyroidism or something like that, clearly that needs to be paid attention to because they're not going to be physically active or something like that. But those kinds of things, or a hypoactive thyroid, they're going to be, their nutrition is going to be off, or they've got biological predisposition to diabetes or something like that. You have to have these medications in place. So I like to look at this in a way that it says things outside of yourself, things within yourself. So the environment is outside of yourself, things within yourself, and biological determinants that might require assistance from a medication or some other kind of treatment. What is required? And it helps the person see, well, oh, okay, I have to sequence my treatment. Okay. All right. So I think we've got a fair number of the ways in which these tools could be used to help set the priorities, and I think that's it. And the main thing is not to jump in to telling her what all the solutions are. When you're looking at this, yes, there are, I think Anna talked about what are the community supports for single mothers with financial challenges, etc. It's, in many ways, you may have the solutions, but if you're going to use a motivation where you're engaging them, we would ask them as to, so what are some of the solutions you see to this problem? We may have the best program, but if they don't see it as a reality, you'll come up with a yes, but I don't think I can make it there. Yes, you're going to start getting that resistance to the advice that you may be giving. So really, when you're dealing with people with these complex solutions, in part, it's getting them to help to problem solve, and your role is more of a coach as you help them walk and navigate through this. Now, it doesn't mean you don't use your expertise and provide your expertise, but you do that with judicious use of permission and say, I noticed that when this column is blank in terms of a solution for the environmental issues around what you can do, there are some programs for single moms in the community that can help you with X, Y, and Z. What are your thoughts about going to one? So it's really keeping the power with the patient, so because they are feeling kind of overwhelmed. This allows them that possibility of choice and feeling that they have some control over their lives. And so really helping them see those things is important, but how you present it is equally important when you're dealing with complex patients with complexity. And yeah, you are going to have, you will know that there are some resources that you can provide, and you do that with permission. The main thing is not to flood them with so many resources that they don't know where to start with. So it's really being that judicious use of resources so that they don't feel like they're running between 500 different appointments to where they're going. Okay, so now coming back to the questions, I think we've clarified these questions about this question about the agenda setting skills and what are her priorities, and it could be any of those. We have no idea. I mean, we can guess, but there could be a whole host of ones in there. Now, what if she does come up with resistance when you're starting to discuss a health behavior? So, for example, she says, yeah, I know I should drink less, but it's easy and it helps me cope and it's the only thing that puts me to sleep. How are some of the ways in which you would respond to that? I can see multiple attendees are typing, but nothing's coming through. Yeah. So, I mean, I think that's right. Julie's got it right. If you roll with that resistance, so if she says, drinking is what is helping me cope, you may say, drinking is what you find as a coping strategy, and that's where you would help workshop on strategies to help settle your nervous system before bed. Would you like to attend the workshop and find out? So exactly. So is a resource that you can offer and say, okay, so in motivational interviewing, this would be called our writing reflex. The patient comes up with a problem, she's providing resistance. One option is to come up with a solution, say, we have a workshop for you that can help you do that, and then she'll say, well, but I can't get there because I don't have tokens, or can't travel, or who's going to watch the kids, or he'll then find out that I'm actually drinking and I don't want that to happen. So sometimes our writing reflex, even though it's the right response in the sense that it's the right solution, the patient is not ready yet, and they're indicating that by saying a yes, but. So often to help the person not get into a yes, but kind of situation, or and you getting frustrated because you're offering solutions, I think what Julie said is you reflect back the statement she made, showing empathy for the difficulty in changing her current behavior. It's really tough going on, and sleep is important. Drinking alcohol seems to be the only thing that helps you fall asleep. That's an important one to demonstrate the empathy. It's not that you agree with it, but that's what you're just letting her know that you're hearing. Because that gives you a segue to then ask, help me out understand what else is good about the alcohol. The reason why we won't go into the issues of saying, I can see alcohol is good for you, and then come out with, but do you have any concerns, is what happens in that situation is it's our version of resistance. It's our version of a yes, but to the patient. And then that just generates their argument back. They'll come back with another yes, but. So to avoid that, if you can actually just do the reflection and then explore with them first all the good sides of what alcohol is doing for them, if that was what she brings up. What that does is it indicates to the person you're not judgmental, that you're curious to know what is happening. And as they're speaking, they're reflecting. By you asking that open-ended question, they actually start reflecting on that alcohol consumption. Rather than becoming more convinced that alcohol is the only solution, they often start then saying, and you can contrast it after a point in time and say, okay, so these are all the good things about drinking alcohol for you. What are some of the downsides of alcohol for you? And then those things start coming up, and it starts creating the discrepancy between the good and the bad of alcohol. So it starts getting them into a contemplative mode rather than staying in a pre-contemplative mode or defensive mode. And so one way to address resistance is something called this rolling head start, and it's a very important strategy to help people navigate that ambivalence around change. It's not for you to navigate it, for them to navigate it, and then what you're simply doing is presenting both sides of the argument in a way that they can hear it. Another option is what Julie says is ask permission to share ideas of what others may have found helpful. And you can say, you know what, here's some things that other people find helpful. And I do that very often when the person is asking me for specific direct advice. And again, ask permission if you do have permission to help her, and that she's going to detect from you whether you're going to try to blame or shame her. Often she might be feeling guilty, but it's not our role to shame her or blame her. So again, all of these things, expressing the empathy, exploring the ambivalence, often in this situation starting off with what is good about the behavior and then contrasting it with what is not good about the behavior, helps the person see the problem without you trying to force them to see it. Because people who see the problem by doing this work actually then have a better insight into their problem. And it's not so much as you trying to force them to see it and them defending against it. Sometimes asking people what they think will happen if they don't stop, sometimes it can lead to, I see no problem. And it might be because they don't want to tell you there's a problem, they already see it, or that they actually don't see a problem. So I think those are some of the things as you're working through this conversation, is to think about how you're going to navigate this interview. in terms of helping them remove the barriers, I think it's a bit further down in the conversation. We say, if you decided to change, what would come in the way? What are some of the things that could be helpful? Who could be helpful to you while you're trying to overcome this? What role do you see for me as your provider? What role do you see for me of your partner, etc., that can help you overcome these barriers? And it's very helpful because that kind of language and that kind of planning helps the person see that there's a path out of this complex situation. Assessing readiness and using a readiness scale is a great idea, and you could do it for each of the behaviors that she has. And that way you have a scale, and in future visits, you can say, okay, where has the readiness gone now for paying attention to physical activity, nutrition, sleep, etc. So you've got all these things, and it's kind of like a dashboard. Every visit, a person can slide. Oh, this is better, this is worse, this is the same, and it helps people see, and you can see over time what is happening to their motivation. So that readiness scale in this complex behavior is a very important tool that I find helpful. Helpful for her and for me to know where we are working and whether the motivation is actually getting worse or it's actually improving. Yeah, and I think, Deborah, you've again summarized it nicely. Each specific behavior, what she likes and does not like about it, and what are some of the options that she's tried, what has worked in the past, rather than getting into dichotomous thinking, looking at it as a continuous behavior. Are there times where she gets better sleep, for example? Are there times where she gets less? Are there times where she drinks less? There are times she's being physically active. Like, what are those exceptions? And in that way, that's how they land up boosting their self-efficacy, because they actually now see that they have been able to do things. They have done it in the past. May not have persisted at it, but they have done it. Again, there's a lot of people who are feeling overwhelmed don't have a locus of control, and which is why we have to make sure we don't take over the control from them, and which is why that the bubble sheet is a very important one, which you can look at together, side by side, or you can hand it to her, have her control it as opposed to us control it, and again, that can help that bubble that self-efficacy go up. Right, and again, our idea in motivation interviewing is not to push any person into change, it's to guide them into change. But you need that healthy tension, and say, we say, okay, on the bubble sheet, what if the person says, look, I don't want to be nagged about this every visit, and you can say, look, that's fine, we're not going to nag you. Do I have your permission to ask if we can talk about it at subsequent meetings? I promise not to nag you, and that's a good place to get to. So I think you're right. I agree. This is really look at what needs to change. Let her own it. Give her that space to own it. Be a guide to her as she's going through it. Now, coming to the SMART goals, generally the SMART goals is you have to be careful that you don't make the SMART goals too early. The SMART goals, if to be smart, need to be really in the short term. What's the person willing to do? It might be simply that they may be willing to smoke outside. And that's all what we want to do. So in the last minute, I just want to make sure we have time for some questions. And as the questions are coming in, I'm just going to summarize that complexity is more the rule than the exception. The risk behaviors, smoking, drinking, physical inactivity, poor nutrition, stress, sleep, and prescription medications are some of the bigger ones that we are dealing with. They all tend to cluster in the same population. They all seem to be causing a huge amount of burden of disease. And if we look at them as behaviors, as risk behaviors for over about 200 chronic diseases, and we start working with these behaviors in the same person, we can potentially make a benefit from a primary prevention, secondary prevention, and tertiary prevention. And the model is to use motivational interviewing as a way to help people set agendas, start working through the barriers that may be in place, and that other sheet helps us take a look at what are the problems that exist in the environment or outside of the person that we can actually fix, the problems within their own motivations and their own behaviors that we can motivate to change, and lastly, the biological determinants that can be helped with medications and other advances to help them, if possible, so that if you add those three things together, you have a biopsychosocial approach to dealing with these problems that the person may present, and that taking it slowly is the key way in which we can get people to take step after step after step in addressing these chronic behaviors to become healthy. So I'll stop now, and if there are any further questions, please type them in. Otherwise, we will thank everybody for their participation and all the people who participated on the question and answers in the column. Okay. Well, thank you. You're welcome. And the evaluations will be sent by email. And if you participate as a group, make sure you email Tanya with a complete list of participants by the end of day today. And this session will be archived, and the worksheets will be helpful. Yep. And the next Teach webinar, Lunch and Learn webinar, is on smoking cessation in the homeless population, and that'll be on Wednesday, August the 26th. Oh, there's a question. Oops. Yeah, I think where people are feeling, I think that's a great question. I'll answer it while some of the other, for those who have to leave, we understand, but I'll just answer that question that Tanis asked. When I feel that when somebody is doing that, I will just reflect it and saying, you know, it really seems you feel powerless. I'll tap into that more deeper reflection. You seem powerless, that there's nothing, no matter what you do, bad things are going to happen to you because it's all out of your control. And that helps them sort of say, yeah, I feel powerless. And I just sit with that, and I understand that, and I accept that that's how they're feeling. And so I have some choices of I can either, that becomes a dead end, I can't do much about it. So the person's feeling powerless, we've acknowledged it, we move on. Or I can use that as a segue to say, okay, given how powerless you are, what are some of the things that you think might need to change outside of you? And how would that change happen? And then I sometimes will help that conversation and say, so are you saying that if that person doesn't stop smoking around you, you will not quit smoking? And then we sometimes brainstorm, and I'll say something like, let's say for a moment that person isn't going to change. What are some of the things that you think you can do that might help nudge something? Or is it completely immovable? And if they say it's completely immovable, then we can't do much about it. We just have to move on to the next topic. Because then, then you just acknowledge that you're not engaging the person, and I'll spend more time reflecting back to the person. So what would be useful to talk about? Is it that you would like to come in and it's helpful for you to vent, and you're not looking for a solution? Venting is all you need to do, and then that's all we need to do. We're not trying to, we're not going into a motivational session. We're going into a venting session, and I'm listening. So clarify